Assalamu alaikum. We will start at 2:10. Assalamu alaikum. We'll start in 2 minutes. Assalamu alaikum. I think we could start now. It's my great pleasure, my dear friends and colleagues, to welcome you all to this Endocrine Club meeting. As many of you know that this Endocrine Club is one of the oldest endocrine forums in the UAE, and that was for more than 25 years, and now it is affiliated with the Emirates Diabetes Society. It has been the platform for sharing knowledge, debating challenging cases, and fostering collaboration among endocrinology professionals. I'm honored today. Let me see. I'm honored today to share this meeting. I'm Bashar Effendi, endocrine consultant at Tawam Hospital. Uh, and I'm really honored that in this session we have distinguished speakers, including founding members of the Endocrine Club, Dr. Ali Khalil and Dr. Ahmed Hassoun, and we have also a prominent speaker, Professor Muhammad Al-Mahdal, who will talk about the standards of care and addressing performance standards in CGM. Uh, after after we finish the presentations, we will conclude for a Q&A session. So please, if you have any questions, just put in the Q&A box, and please specify the speaker you're asking. Again, please put your questions throughout in the Q&A box. And now let's move to the first presentation by Professor Ali Khalil, who is well known to the audience. He's a consultant endocrinologist currently at Reem Hospital, and he's a founding member of the UAE Endocrine Club. He is an adjunct professor at the UAE University, many senior positions at many institutions. Very proud to have you here, Dr. Ali, to review your case. Dr. Ali, the floor is yours. Yeah, we could see your slides. Dr. Ali, the floor is yours. Dr. Ali, can you share your slides?
Yes, Ali, we can see you now.
Dr. Ali, share your slides.
Yes, Sabrina. Hello. Hello.
Dr. Ahmed, would you like to do your presentation? Then we will
Okay,
go back
fine.
to.
Thanks.
I think he's going to share.
Okay.
Yes, very good. We can see the slides, Dr. Ali.
Okay, can you hear me?
Yes, we can hear you and see the slides.
Hello.
Yes, we can.
Can you hear me?
Yes.
Hello, Sabrina. Can you hear me?
Yes, 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 we can hear you. Dr. Ali. No, no.
He's mute.
He's now muted. I'm not sure. I mean, it looks like whenever he's mute, he's the other way. Let me call him again.
Ali, we cannot hear you.
Dr. Hassoun, can you share your presentation? We'll get back to Dr.
Yeah.
Ali Khalil later.
Okay, let me do that.
Sorry for that. And
Let him-
Dr.
I
Ali,
need to share.
yeah, sure. You could share now.
He has to, I think,
Stop
stop
sharing.
sharing. Yeah.
I could see your.
One second. Let me just prepare myself here. Okay, good. Let me try to zoom in and see if I can do it myself. Let me see here. Yes, I will try. Sharp. All mail. I think he needs to stop sharing.
mean, Dr. Ali?
Yeah. Let me see. 1 second.
Yes, now we could see your screen, Ahmed.
You can see my screen then. Okay, let me go to the presentation. Here we go. Can you see it?
I could see MCI group screen, but it says Ahmed Hassoun screen.
It's not showing? Okay, let me try again. Let me try again. Zoom, here we go. Sharing, share. Yes, I think now it's going to work. I hope, yes?
Yes, excellent. Thank you very much, Dr. Ahmed. Dr. Ahmed, you're well known to the audience, one of the founding members for the Endocrine Club. Please start your presentation.
All right, good. Thank you very much, Dr. Bashar. Thank you for everybody. Thank you for our co-speakers here. And it's good that we're starting this one as, online. Unfortunately, we are not able to communicate and interact. Hopefully in the future will be different. So I'm presenting this case with the title of When Hypoglycemia Isn't What You Think, A Tale of Two World Cups. And this is my hospital where I'm practicing. Nothing to disclose for this presentation. Starting with this case that visited our endocrine clinic in October 2025. That's a typo. So that was the time when we saw her, but she has a history before coming to us, which I'm going to talk about it more. So here we go. From May 2025, symptoms started with her. Basically, symptoms of like recurrent hypoglycemia, including fatigue, dizziness, irritability, memory issues, and some recording of sugars being as low as 31 milligram. Minimal improvement with diet modification means that she started to reduce the diet and the carbohydrate, but that did not help much. Continuous glucose CGMS monitoring done for this patient and showed some frequent low readings, variable from very low to a little bit low, and for sure some normal reading as well. So patient visited, she was in Abu Dhabi at that time, and she has some reports that provided to us done in Abu Dhabi. Let me see if I have them here. Talking about when she joined us, and we said now this is recently in October here. Her current complaint when we saw her was unremarkable, except for the symptoms of looks like non-specific, but could be fatigue related. I mean, hypo, fatigue. She had some weight gain, although her weight is not really very high, but occasional also dizziness. As we said, she is a lady. She is 39-year-old. She is from the UK. Past history unremarkable. Surgery nothing remarkable except cesarean section 1. And the medication, she was not taking any regular treatment, basically, or even any supplements. Family history, nothing related to our complaint here, nothing significant, actually, unremarkable. She's Caucasian, non-smoker, does not drink alcohol. Nothing with allergy. As I said, lower carb diet, she has been trying to help herself with that. And that was also, she was not regular exercising. That's, I think, when we saw her in our hospital, and that's her height and weight. BMI, she is on the thinner side, 21, almost there. Blood pressure good, heart rate is okay. And then you can see that everything is within acceptable range. In her exam, actually, there is nothing much, as you can see here. Well appearing, as again, her weight is within the normal range. Nothing in the eye examination. I highlighted for you the palpable left thyroid nodule, measuring about 1.5 to 2 centimeters around that by palpation. Otherwise, lobulated gland, chest exam, nothing, heart, nothing. There's really unremarkable findings otherwise. Healthy looking lady. So that's her initial lab. That is not with us. That was before coming to us. That's in May. As I said, her story started in May. And you can see that HbA1c they did for her in Abu Dhabi, and that was showing that's in the lower normal range, normal. And the insulin was 3.2. Cortisol is within normal range as well. And then they decided, because of her symptoms, to check on C-peptide, and that's the C-peptide shown here. But then said that let's go ahead and do oral glucose tolerance test for the patient. And that was what's done, actually. And you will see it in the next page, including the insulin measurement during that test as well. So here we go. You can see that 70 grams done, fasting sugar good, 79, 175, 92. But again, you can see the insulin level down there. The third hour, I will show it to you. And here's the third hour during that test was 31, with insulin at the third hour was 5.4. It's not suppressed. So now let's stop here. Unfortunately, we cannot interact much, but think about it. You have this patient who have, a high, low sugar, significant low sugar during this test, and the insulin level at the third hour was, if anything is not suppressed, I will call it. All right. So I think the thinking in Abu Dhabi for the team who were working with her about that, okay, this looks like insulinoma because insulin is high and the sugar is low. Let's work into insulinoma. And that's basically the suspicion, and they start working on that. And first thing they did, ultrasound of the abdomen, done soon after that, and showed here, as you can see down in the impression, no significant pathology. And if you look at the pancreas here, also mentioned liver and all this gallbladder, aorta, pancreas, nothing really remarkable, right? So they decided, well, we need to find something else somewhere else. And then they look into the MRI of the pancreas they did with contrast. That is later on, because she continued to have the symptoms. And for that reason, she kept going to follow on to see what's going on with this. And just to make it short, this is MRI of the pancreas. And they mentioned in the MRI of the pancreas in their report, there is a subcentimeter nodule diffusion restriction, as you can see here. In the infrapancreatic region. I don't think we have that slice with us here, but suspecting insulinoma, and they recommended doing, the PET scan if clinically indicated. So because of the clinically indicated, thought that it was need to be investigated further, and they did not, and they find this some suspicion here. She went to do the PET scan. And the dilated PET scan, just to make it short for you, it was not showing any significant thing actually, except that, I'm not sure if it's showing here, in the thyroid, left thyroid lobe, there was activity there. And I can see that here, what is written, that there's no focal or discrete pancreatic lesion. That's what they were looking at. And, they see the left lower pole of the thyroid showing this activity, and they ultrasound recommended, and fine needle aspiration biopsy was recommended. This is just to continue the same thing basically. And I think this is the thyroid, ultrasound. I don't have all the details of it, but basically, sorry about that. Let me just move on quickly here. Okay, so the ultrasound of the thyroid done later on confirmed that also what I saw earlier, that left thyroid lobe mass inferiorly. So now they could not find anything in the pancreas, thinking that she has insulinoma. They found something in the left thyroid lobe. What they should do, patient get, in a way, thinking about it. She was looking for other regions that maybe somebody can help her to find where is this insulinoma, if it is there somewhere. And she get in touch with us actually through some common friend that she knows and been under our care here. And I think if I move on, so she visited our endocrine, as I said, in October, advised by a friend, as I mentioned earlier. So the initial differential diagnosis to be thinking about it even before coming to us is it insulinoma, is it reactive hypoglycemia? All of us should think about these factitious hypo, hormonal endocrine causes, or thyroid-related pathology. So after reviewing the history in the multidisciplinary meeting, we discussed the case and reviewed everything we have from done outside, and reviewed even the PET and CT, then recommended that, which, strongly recommend that we should go for the 72-hour prolonged fasting. So the patient agreed and came from Abu Dhabi to do the test. And that was how we done it, standard way of doing it, checking it earlier every 4 hours, and then slowing down, the frequent become more when the sugar becoming near to the hypoglycemia range. And on the night of the 24th, so this she was on the 23rd, on the night of 24th to 25th, she developed symptoms of nausea and had vomiting episodes. On the 25th, 4 o'clock in the morning, her sugar went down. I mean, she was keep complaining to stop it, but we were able to convince her to carry on. So she continued until she reached 41, and that time we took blood samples to do the testing. As you know, most of you probably know the protocol about doing that. So, and then also later on after that, I, resuscitated with the sugar, IV glucose as well as glucagon injection. The glucagon is for a reason also, as you know, for a test. So let's see what happened here. She was vitally stable after that. She was okay after corrected her sugar. So she has symptomatic hypoglycemia, sample taken, glucagon infusion administered, and here are the results. So you can see that here that we have the insulin fasting is on the lower side, free insulin also measured, the same thing. C-peptide on the lower side, 0.85. Pro-insulin was on the, I would call it, according to this is low normal, but it's low actually here. And the beta-hydroxybutyrate is high. So if you are with me sitting in the meeting room and discussing it, I think we can interact there, but unfortunately, you can interact online, okay? So the glucagon infusion also administered the injection and found that she was, as you said, 41, 42, then she jumped into 79 milligram. And that is means something, as you probably see, and probably as you know that already. So that's significant increase, more than 25. So with all this we found, we thought this is not consistent with insulinoma. And I would probably show a slide here that comparing a patient, some of you heard me presenting this case before. I'm not going to present it just to show you the difference here. So this is the other patient that we have seen before. And actually this patient told this patient from Abu Dhabi to come to see us, thinking that a case is similar, which we will see later what's really the end of this. So that's the other patient who has sugar clearly by CGMS was showing that low, most of the time low. Actually, she could not stay without eating frequently. She gained a lot of weight that time. And that is the old patient. She's not old by age, older than this one in our visit here, showing this 72 hours. We did repeat it. She had some investigation before, but we did the proper 72 hours here complete, as you will see here. And then she dropped down to 42. And by the way, this I did it differently because I know that she will run low and she cannot stay 2 hours. So usually, as you know, that you tell them fasting from night to come in the morning. I told her eat breakfast in the morning and come because I know she will drop after breakfast, even in maybe 2-3 hours from the history. So here we go that this is the test done. It does done very well. And you can see here that the insulin was 21. Pro-insulin is very high. According to the normal value in the lab, which is something important to remember, really need not to think about the normal value, but even in the normal value for pro-insulin is very high here. And the others are, mentioned, as you can see, including C-peptide, beta-hydroxybutyrate. They also did cortisol. We did cortisol and insulin growth factor as well. Now I put these two cases together for you to compare. And you can see here the sugar, and the bolded color is the standard and how to diagnose. So blood glucose should be less than 55, the criteria, or less than 3 millimole. And our current patient was 41, which justified the investigation. Our last case was also around the same figure, 41, 42. The insulin at least should be 3 international, I think, units per ml or in picomole. And our patient was 1.7, so it's not reaching the 3. And the other patient that I told you clearly showed hypoglycemia and was diagnosed with insulinoma, actually showed 21. C-peptide in this patient should be at least 0.6. She was above 0.6, but slightly above, and it is on the, actually, if you look at the normal range, it was low, but it's above the 0.6, that the criteria we usually use. But you can compare it with the real case was 2.37, clearly above the 0.6. The pro-insulin in this case that we presented today was 1.4, while the other case, the confirmed case of insulinoma was 60, clearly high. And importantly, again, to remember that beta-hydroxybutyrate should be suppressed with people with insulinoma because of the insulin effect. And in this patient actually was high, and that goes with the fasting, inducing the increasing ketosis in the patient. This is I think, our the patient that we diagnosed with actually insulinoma, and it was a very difficult case. After knowing that patient had insulinoma, I'm not going to repeat it because I presented in the GAID meeting maybe 2 years ago. It was difficult to localize. The diagnosis was clear, localization was difficult, went to UK, went somewhere else. Then the advice was to go to India. In India, there was people doing the extending PET scan. And she did it there, and you can see it here highlighted very nicely there. And they find the localization. They did many things before that, by the way. You can imagine endoscopic ultrasound, other imaging, and all was not showing. Only the extending showed that. And that was the surgery done here in Dubai and was successfully removing all the tumor itself. It was not very big, but it was not very small, but was hiding, in the region. And you can see that was our old patient. He was low, and after surgery, she was excellent in normal range. And by the way, I kept in touch with her, and she was a few months ago. She told me, somebody told me she's pregnant, and she delivered a daughter, healthy and everything fine. She didn't have any episodes, so a successful surgery done for this patient. Now, the final diagnosis of our patient here is hypoglycemia, but non-hyperinsulinic. Insulinoma really ruled out. Non-toxic, she has also single thyroid nodule. We continue glucose monitoring advice. We advise her to have high protein, high fat, and then refined carbohydrate to avoid basically, and advised to go for the fine inspection biopsy in Abu Dhabi. And I think, as we will come to later, I think she did have that already, and I'll let you know about it later on. So, an endocrine follow-up, whether with us or with the Abu Dhabi team. And basically, this was also advised by us because of the thought process before. Is it, another tumor? Is it MEN, something like that? So calcium was checked. Parathyroid was checked, and everything goes within normal range. Calcitonin was also checked and was also low. So insulinoma ruled out, calcium negative, recommended FNA, as we said, and this is basically the FNA. First, I think this is the MRI of the pancreas. This again is something important. The first MRI of the pancreas, if you remember, that's not done with us, by the way. That's done with in Abu Dhabi again. The first MRI showed there's some question about something in the pancreas, but in this one you can see there is nothing seen in the pancreas and passed as a normal pancreas and normal, generally speaking. And then you look into the biopsy of the FNA. I think this is the FNA here, yes, and it was a thyroid nodule, good size, was Bethesda 2, category 2, and the patient is doing well. I'm not sure how much time we have, Mr. Chairman. But just a few slides to just give you some idea to the people we need to refresh our memories about this. So we have insulin-mediated hypo, we have non-insulin-mediated, like this case, for example. So the insulin-mediated exogenous, could be somebody taking insulin, taking oral agent, endogenous oral agent, insulinoma, and others listed here. And this is a reference. You can take this reference. It's a very nice reference having this important, details of how to approach this thing. Non-insulin mediated critical illness, adrenal, and nutritional metabolic, and all this other thing, non-insulin, non-island cell tumor, and so forth. And this is just, I don't think we can go at this time in the details of this. But basically, going back to what we have to do, and everybody is doing that, I'm sure that confirming first we have a Whipple trial. And if it is yes, then consider is the patient is ill appearing or non-ill appearing. Ill appearing, you're thinking about critical illness. Non-ill appearing, you're going to direct, like in our cases here, to measure these markers for insulinoma, for example, or high insulin level. And if it's high insulin level, insulin mediated, again, you can see that could go to insulinoma, or could be somebody getting insulin from outside. And there's some differences with the measurement. You can see the differences between the exogenous, that you have low C-peptide because you're getting insulin from outside, and low pro-insulin. On the other hand, if the high C-peptide, like the second case we have, the older case that we have high C-peptide and high pro-insulin, then you're thinking about more of an insulinoma or something, in that regard of stimulating the pancreas to secrete more insulin. On the other hand, if low insulin, non-insulin mediated, again, they will be low C-peptide, low pro-insulin, high, like this case actually, and that end with being non-insulin or IFG. I think IFG was probably done because of that reason. It was negative. But I think there are other causes from IGF, different than IGF, IGF-2, and that was not the case. The reason is we get in touch with the patient several times after that. There's no hypoglycemia anymore by changing the diet, clearly about the carbohydrate. And she's not getting anything significant anymore. She was very happy. Actually, we just recently got this reports from her about the FNA and this. And she's doing very well. And let me just see what I have here for you. This is some of the medications that can cause hypoglycemia, basically here with a different way of doing that. And there's something called ackee fruit that will also cause hypoglycemia. Again, the same thing, we just talked about it now. This is repeated apparently. And this is the last thing, probably the glycogen storage disease associated with hypoglycemia are listed here. And I think that's beyond us. Usually this in younger people, and they need to be diagnosed early and they need to be studied genetically as well. And this is probably from what's up. I would like to probably stop here on the next slide, showing that the sensitivity and specificity of the different way of imaging. And you can see if you go down to the somatostatin, for example, 50-50, and then if you look at the last one, or before the last one, GLP-1, which is extending PET scan, you can see how high sensitivity and how high specificity. And that's what our first patient did, actually. And I think this is what basically was just a new point about this one published in the JCM, is that if you have, indolent localized solitary lesion, talking about surgery or radiofrequency, actually, which is something apparently recently been talking about it. And in our case, we're not having any metastatic lesion. So I would stop here and thank you very much for listening.
Thank you. Thank you, Dr. Ahmed. Excellent cases and diagnosis. Now, I'm sure that the first patient was really lucky not to have pancreatic incidentaloma and go for surgery. So we'll move now to the second presentation. I'm sure we have a lot of questions.
So we have no time for questioning. I think the panelists.
No question now. We'll do it later.
Question? Okay, fine. Okay. So I'm going to share my slides. Yeah. Okay. Can you hear me?
We can hear you, but we cannot see the slides yet.
No, really?
Really? It was there. You stopped it.
Oh my God. Okay, fine. Let's see again. Next. And show.
Dr. Muhammad, get ready.
Sabrina, can you put my presentation? You can maybe share. Can you see the screen now or no?
We cannot see but you. Nice face.
But I don't see my face now. I don't know what's happening. Sorry for that. Slideshow here. Do you see the presentation? No.
No.
No? I don't know.
Sabrina, are you around?
Sabrina, let me try one more time. Okay.
Yeah, I think now we almost seeing.
There is progress.
Yeah.
Yeah. Now, do you have to see the presentation now?
Not yet. We see Ahmed Hassoun now. And myself.
We see your screen.
I don't know what I'm trying.
Yes. One more. No.
No, I need to get the presentation. It's not. Sorry for this. Yeah. Sabrina, I sent her my presentation. Maybe she can put it through. Wait. No, I lost it too. Yeah, no. Can you see it?
Yes.
Yeah?
Yes.
Yes, okay. So I will not be as exhaustive as Dr. Ahmed. Just to give you a very simple case, I'm sure it's going to be like intuitive thinking for all of you. This is a case of a patient I've been seeing since for the last maybe 5, 6 years. She comes every year for just to have an ultrasound. She's known to have chronic atrophic thyroiditis and hypothyroidism on levothyroxine 75 microgram once daily. She's well controlled. The TSH is normal, and she's clinically asymptomatic, except for maybe some mild overweight. She has been menopausal at the time when I saw her at the age of 52. That was September 2022 for 1 year, but she was asymptomatic. She had vitamin D deficiency well replaced. Hyperlipidemia with low HDL diet. She refused to go on statin. A little bit of functional dyspepsia managed with occasional PPI inhibitor. And she has been, for the last 3 years, followed at CCAD for what they call non-functional adrenal adenoma on the left side. And they have been following the size. It looks like in change. And they were happy with just managing and following the size. So because she comes only once a year, she came the year after. I was just had recently moved to Ream Hospital. Her thyroid condition was stable. She was still overweight. And she was checking her sugar from her husband meter, and occasionally her sugar will be a little bit on the high side. So I asked for hemoglobin A1C was normal at 5.5%. I'd advise her weight loss and maybe to do some more exercise. And again, I lost her for follow-up till July 2024. At that time, she came, thyroid status again was stable. She BMI was a little bit on the high side. And for the first time, so at the age of 53, hemoglobin A1C turned out to be 6.5%, totally asymptomatic. So we said, let's try to lose the weight. We'll give you some Ozempic, you can start on that, and we give you on some metformin, which will address your blood sugar, being now type 2 diabetes. And again, I lost her for follow-up, and then she came in like around February 2025, that's really a few months later. And what interesting point that she was looked after for her diabetes, which became really difficult to control. She became cachectic and lost a lot of weight, and she had that extensive vesicular and bullous rash, severe pruritus. You would be seeing her watch in the office, just scratching her skin as much as was severe, and it was generalized. And this is not her lesions, but I took it for just analogy, so you'll see. And this is a little bit closer view. You see those bullae, just and then the redness, and then the lesions. So no precipitating factors were felt to be present. She was already on really adequate number of medication to control her diabetes, which became difficult to control, blood sugar running constantly around 250 to 260. She was on DAPA metformin twice a day, Diamicron 2 tablets daily, Ozempic 1 milligram weekly, and she was really wanted to stop Ozempic because of significant weight loss for good reason. So they did a biopsy, skin biopsy, and then they gave her a course of steroids for 2 weeks, and they started after that on biological treatment. So the diagnosis from the skin biopsy was bullous pemphigoid. The bullous pemphigoid, for those who really just wants refreshment in what it is, it's an autoimmune skin disease. There's a reaction, inflammatory reaction against some antigen in the epidermis. So when those are affected, they form lifting of the skin, and that's how the bullous formation get formed. It's considered to be autoimmune, difficult to control, and they need steroid. Normally it happens at the age of 60s, above the age of 60, for unknown reason, just a triggering of the immune system. So with this in mind, so we have this patient, 56-year-old lady. She's known for chronic thyroiditis, autoimmune thyroiditis. She has underlying adrenal tumor that was labeled as non-functioning adrenal tumor. And she has another autoimmune skin disease, which is called bullous pemphigoid. And now her type 2 diabetes is very difficult to control. So I would have liked to have it interactive, but it looks like we cannot do it. So the differential diagnosis here, we can think about, since you have two autoimmune disease, are we dealing with polyglandular autoimmune disease, and you have two types, type 1 and type 2. The one type 1 is associated with candidiasis and usually occur in children, but you don't get that type of eruptive skin lesion. And in the type 2, where those seems more commonly seen, and you don't see adrenal tumor, you see adrenal insufficiency, and you don't see uncontrolled diabetes. If anything, you see improvement in the diabetic condition if present. And this is type 2, and the skin lesion is usually vitiligo rather than the type of bullous pemphigoid that really that patient presented. The second thought that you might think about it, did we have a reactivation of the adrenal tumors? Occasionally, I looked at the literature, the occasional cases labeled as non-secreting adrenal tumor, they become really secreting tumor. And then for this, some of the tests that really were done in at CCAD, actually, where she was followed for her adrenal tumor. And here you could see, you can follow with me the CT scan. And then here you can start seeing the kidney on the right side. This is on the left side. You can see the limb here of the adrenal. This is the mass. And the whole limb is a little bit enlarged. Now, if we look at closely, this is you could see it on a static lesion here. And she had some hormonal testing done. Aldosterone was normal, renin was normal, aldosterone over renin ratio was normal, norepinephrine and epinephrine were normal. And they did dexamethasone test, which I repeated again a few months later, and she cortisol suppressed to less than 50 nanomole per liter. So she had adequate suppression. So there's no what we call like maybe excess adrenal secretion of cortisol to explain that change in her diabetes status. We are left with what they call the autoimmune diabetes, which is the late onset diabetes type 1. And for that, you need to do some antibodies. But again, in my mind, this is the type that you usually see like earlier than the age of 52, not so much at that late age. That's why initially I was skeptic that those tests will bring something different or something new. But again, to my surprise, they came all positive. For GAD antibodies were positive. They were 10 unit per milliliter. The IA2 antibodies were also positive. And the C-peptide, normally you should expect it if the pancreas is secreting normally to be more than 1 nanogram. It was less than 0.3 nanogram per milliliter. So this was the message from this is that even if it's really that sometimes this is infrequent condition, if you have underlying autoimmune disease, think about possible late onset type 1 diabetes. Now, a few words on type 1 diabetes. One, we call it type 1.5 diabetes. And why we call it type 1.5 diabetes? Because half of it is on the side of type 2, so it can present like type 2, mild overweight, symptoms, mild hyperglycemia, control with medication. And the other half that it's in type 1 diabetes with immune markers for islet cell antibody being positive and ultimately becoming insulin dependent. Prevalence more frequent in the Scandinavian area where type 1 diabetes is frequent, estimated to be 7.5 to 10% of adults with apparent type 2 diabetes, less so in certain other regions. Genetically, it's interesting that genetics of this presentation, it shares genetic feature of both type 1 diabetes and type 2 diabetes. For instance, you will find the HLA-DQB1 genotype that you see with type 1 diabetes, and the TCF transcription factor 7L2, what you see with the metabolic type diabetes. And then you think about the late onset, you suspect it if the age of onset is more than 30, if the BMI is low or normal BMI, not typically overweight. In the present, you have to have at least one, if more antibodies is better, GAD, ICA, or IA2, or maybe zinc transporters antibodies. And normally they fail to respond to oral antidiabetics, the same as would happen in our patient. And explain weight loss, which again, what happened in this case, and a low C-peptide level. So how do you link it to the pemphigus? Pemphigus, it seems that it does trigger the immune status and unmask a state of latent late LADA type that has been dormant. And that's really the relationship, which I found it really fascinating. And with this, my case is at its end, and thank you very much for listening.
Thank you, Dr. Ali. We'll get back again. Please, if you have any question for Dr. Ali or Dr. Ahmed, just put them in the Q&A box, and we'll get back to the questions after the last session. It's my great pleasure to present my dear friend, Dr. Muhammad Al-Mehdal, who is a consultant in endocrinology, diabetes, and diabetes technology, and islet transplant. He's the medical director and diabetes technology section head, Obesity, Endocrine and Metabolism Center at King Fahd Medical City in Riyadh, Saudi Arabia. Dr. Al-Mehdal is well known to the audience. Thank you for joining us, and the floor is yours.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Bashar, for the nice introduction. And thank you very much for the endocrine diabetes and Emirates Endocrine Diabetes Society for inviting me to give this lecture. It's a pleasure to join you guys. So I'll talk today about the performance standards for CGM and why these are important. These are my disclosures. This is how we get approval for CGM devices and medical devices in general in Saudi Arabia. I don't know if it's the same in Emirates or not. Probably they follow the same standards. So if the device has an approval in Europe, or they got the CE mark, or if they are approved in USA by the United States FDA, then they got automatic approval from the Saudi FDA when they get what we call it MEDMA, or Medical Device Marketing Authorization. It's like the approval for device, like the approval for medicines. So let's talk about the CE marks and how it is done. So we here try to define the point accuracy between CGM and the standard. So the point accuracy is the closeness of the arrangement between a glucose test, which is test result and the accepted reference value at a single point in time. And this is what we are trying to do with the CGM. So we want to see how accurate is this. So what is the accuracy parameters that we use most of the time? Probably you are familiar of the MARD, or the mean absolute relative difference, which should be differentiated from the median absolute relative difference. So let's see here an example. You can see in the left, the far left column here is the gold standard glucose, which most of the time venous or capillary glucose. And on the second column here is the sensor readings. The deviation from the gold standard is done here. So you can see the deviation between 11 and 10. So the deviation is 1 from the gold standard. The absolute deviation is how far is the CGM reading from the gold standard. And you can see here between 1 and 2. And what percentage deviation. So we divide the absolute deviation over the reference glucose, and we come up with a percentage point. So 10% here, and so on. Then we take the mean of all these percentage, and that's called the mean absolute relative difference, which is here 11%. The median, which takes out the outliers, it may give you a better performance, which is probably should not be used instead of the mean. So this the mean, the MARD is not the only thing that we should follow. Let's see here. I'll give you an example. If you have a team and you want to buy a striker for your team, and you have these 3 options. You have Cristiano Ronaldo, you have Messi, and you have Mohamed Al-Mahdal, obviously. All players scored over, for example, 800 goals, and that's the MARD. That's just reflects the MARD. So all of them have MARDs of 10%, but the price is for Mohamed Al-Mahdal is half the price for the other players. So it would be logical in this case to choose Mohamed Al-Mahdal, but you will not do that before asking a few things. What standard your goals were scored at? So you can see, is it like top leagues? Is it national, international? So you can see Messi and Cristiano where they played in the top leagues, and also played for internationally for Portugal and Argentina. Mohamed Al-Mahdal played with Al Qarra team and Al Noor team in the out of nowhere, right? The 3rd league in Saudi Arabia. So this is.
We don't care. We want you. We don't care.
I hope not. But if this is your team, you will probably you don't want me. You want Cristiano or Messi. So study design is very important before performance. So let's see the CE marking in 1993. This is usually they are general standards. There is no CGM or automated insulin delivery specifics or harmonized standard for these devices. There are 2 categories or 3 categories, the 2B and 2A. So 2B, which is the highest standard, which for moderate to high risk devices.
Why?
And they can be
Why I
used
cannot
for.
hear I have issue with this.
Dr. Ali, I think
I did this maximum.
For the device to be really approved for decision making, it has to be at least 2B to meet a moderate to high risk. But we can see some CGMs in the 2A categories, and they are approved for decision making. The intended purpose here. So intended purpose is not specific really for any CGM. And it's not specific for diabetes type or population. So they can just say this device is intended for the measurement of blood sugar levels. And they can get approval in all population, pediatric, adults, type 1, type 2, and gestational diabetes and everything. The clinical safety, it should be the device should be free from any acceptable clinical risk when using the device according to the manufacturer instructions for use. So they depends on the manufacturer instructions. So there is no really assessment by any other agency. So there is no clear guidance on how to assess clinical data for CGM, and experience suggests member states are very unlikely to act to these risks. So, for example, here we can see these devices, you can see they got the CE mark for ages, for example, above the age of 2, but see their clinical data is done on adults, not pediatrics. And despite that, they got approval to be used in pediatric patient. So we need to really review the clinical data to really judge on the CGM if it is really good or not depends only on the CE mark criteria. From the 2019 criteria for CGM, it says that at least 70% of the population of the patient should be type 1 diabetes. And that's really important because these are the high-risk people, and the variability for the blood sugar for these people is high. So this will reflect really the accuracy of the CGM. If I have a CGM and I want it to really look accurate, I would use probably more of patient with type 2 diabetes because they don't have lots of variability like type 1, and my CGM will appear more accurate. And you can see here some of the approved devices by by the European agency is they lack the required percentage of patient with type 1 diabetes. So you don't want any CGM, or you don't want to drive a car which only tested in the middle lane in a moderate speed. You want a car which is tested in all lanes with a high and low speed, and this applies to the CGM. You want a really CGM which is really tested in the normal range, hypo and hyperglycemia range, and in all speeded. So fortunately, they changed the criteria for CE marking 2017. They improved it, but you can see, as you can see in the top here, the what we call it Godfather clause. This will will not work until 2028 or not be applicable. So all the devices that got approval in the 1997 criteria will be still approved until 2028. So the new criteria, so any device that require a class 2B or 3, they require clinical investigations specific for that, not rely on equivalent data. There should be a sufficient accuracy, precision, and stability for their intended purpose. So the intended purpose should be specified: type 1 diabetes, type 2 diabetes, and the age group as well. Or the highest standards or class like 3 and 2B, then they need to assessment by European Medical Agency as well. The intended purpose should be clear, and as we said, type 1, type 2 diabetes and the population. The clinical, there should be they should follow ISO standard for CGM, which is currently not available. It will take up to 2 to 3 years to get an ISO standard for CGM. And clinical investigation performance study should be searchable and should be available for anyone who wants to review them, not like the other criteria in 1997. Has this worked? Let's see. So there are some devices which is approved after the 2017 criteria, and you can see, for example, SciJoy CGM. And if you look into their study, only 50%, 56% patients have type 1 diabetes, which should be more than 70%. There was no meal or insulin challenge, and only 6% have low reading, which should be more than 8%. Another example, Glonovo CGM, only 32% of the patient has type 1 diabetes, and there was no data in the hypo or hyper range, and there was no meal or insulin challenge. So now moving to unlike the ISO standard or the CE marks, US come with criteria like called the iCGM. So to get approval in United States, there are two options. Number one is what we call it class 3, which is the highest. or the other one, which is called the ICGM, or 510K pre-market notification. So for class 3, this should be a specific study done for that device, which is the highest really standard for any device. So there should be that specific study for the intended population for use, and this is the highest standard for approval, but it takes time. So they come with this class 2, or the ICGM criteria, which is intended for pre-approval of ICGM or CGM devices. So the clinical data with a clear population is indicated, all data transparent and published on the FDA website, and there will be a clear post-market surveillance for the device. So the design verification must include the following: intended use population, it's type 1, type 2, or gestational diabetes, or whatever population you want to use this CGM on. There should be a lab-based glucose measurement method that's precise and accurate. And the clinical study should be designed to fully represent the performance of the device throughout the measured range. So, for example, if you want your CGM to be approved from 50 to 300, then you need to test in those ranges. There is lack of specificity in how to measure throughout the range. Does it include meal or insulin testing, and also there is a lack of specificity for the comparator. But I think this is a huge step forward. So now, once you define the standard, then you can test the MARD. And so the MARD, or the mean absolute relative difference, which is, again, it is a mean. So the problem with a mean is not really reliable. So, for example, if I tell you there is this river, which is on average 4 feet deep, or that's around 120 centimeter or so, and you do not know how to swim. So if I ask you to swim or to cross this river, would you say yes or no? Hopefully, most of you would say no, because the average is not really reliable, because some areas could be 1 meter and other areas could be 3 or 4 meters deep, and you might not survive if you try to cross this river. It's the same for glucose. So if you only test this, for example, the mean in the normal range, then this will not be reflecting the low and high range. So you need to test it also in the low and high range and get the average in those areas. So once you define the standard, then they require certain rules. So they call it the 15-15 and 40-40. So what are these rules? So for time below range, less than 70, so 85% of the CGM reading should be within 15 milligram per deciliter. So if the blood sugar CGM reading is 70, so it should be between 65 and 85. If we compare it to the gold standard. And 98% of the reading, it should be within 40 milligram per deciliter. So that's, you are allowing only 2% for a huge change of the reading. If the blood sugar is within range and above range, so within range, only 70% of the reading, it should be within 15%, and 99% of the CGM should be within 40%. And time above range, you can see 80% of the reading should be within 15%, and 99% of the reading should be within 40% of the gold standard. There are also special accuracy and control performance on some readings. So when ICGM value or the CGM value is less than 70, no corresponding blood sugar value should be more than 180. So because this will result in really catastrophic decision by the patient. If their blood sugar reading in the low range, it should not be read in the high range. Otherwise, they will give themselves insulin and they might harm themselves. And when the ICGM is in the high range, more than 180, no corresponding blood sugar shall be less than 70 milligram per deciliter. And there are also some control and accuracy requirement for the change in blood sugar. So no more than 1% of CGM measurement that indicate positive glucose rate of change greater than 1 milligram per deciliter per minute, when the corresponding true negative glucose is minus 2 milligram per deciliter per minute. So there should be some accuracy and control requirement about the change or the rate of a change of blood sugar compared to the gold standard. So this is the summary of this ICGM criteria and the overall sensor accuracy in the low range, in the normal range, and in the high range, and also the rate of change accuracy. So there are these standards that should be followed. So FDA knows that MARD is not really a great metric, so they want other CGM criteria to be approved to make sure that we have accurate and precise CGM to be used for our patient. And we want to use a device which is not risk-free, because there is no free ride, but at least we know of a known risk that is acceptable to us to use. And one thing to mention also, in the ICGM criteria, they require the ICGM target of more than 85%, lower the bound of confidence interval. So they do not consider the point estimate. They don't consider the lower confidence limit to make sure they reach the really highest standards and accuracy for the CGM device. So these are some of the devices that probably some of them follow these or meet the ICGM performance standards. Most of them Freestyle, Libri, and Dexcom. And there is another one which maybe I will put it also, the AccuCheck Smart Guard CGM. Some European experts also gathered and tried to address this problem with CE marking, and they come up with some recommendation. So the population, they required at least 70 to 75% of the population to be in type 1 for the CGM to be of good standards. Their recommended meal and insulin challenge, the 8% of the reading should be less than 70, and 5% of the reading should be more than 300. And they also followed the performance criteria in the ICGM performance standards. A problem solved, not completely. There are two things. So we do not want only to test in the normal range or the middle lane, high range, and below range. Also, we want to test when the lane is changing, and also when the blood sugar is really changing within high, low, and within range, because this is what happens really to our patient. They move from low to normal range to high range very quickly sometimes, and we want these CGMs to be accurate. So that's what we call it, the dynamic glucose region challenge. So they want all the performance or all the levels to be tested, and not only that, and also when the blood sugar is changing within each category, hypo, hyper, and within range, by using meal and insulin challenge. So what other things other than the dynamic glucose region testing? So the comparator standardization. So some CGM use capillary blood glucose to perform the comparison, some venous and some arteriovenous. I think this should be standardized all over, and there are some 5 to 10 differences between these three measurements. So I think if you give me the choice, probably the capillary blood glucose will be the most accurate, because Really, this is what our cells is exposed to and what it can harm our cells. Why comparator standardization? Number one is for safe, effective, and consistent clinical decision making. Number two, less discordance and inconsistency with hemoglobin A1C. Number three, CGM metrics to be used as primary endpoint in clinical research. Number four is for people using CGM to do not get fooled about real complication risk, because these are what is really reported in the literature. So we need standardization for that. ISO standard, as we mentioned, it is in the way, but it will take maybe 2 to 3 years until we see it. But why we should see this? Because we want the notified bodies to be universal. So one agency that will really approve the CGM, prevent regional variation, and once artificial and real innovation in functionality begins, size interoperability and AI-driven insight will be used, and we want really the standard of CGM to be the same. There are other benefits other than the accuracy and precision. For example, sales price and versus overall net cost. So you can consider additional costs like transmitters, readers, any additional finger pricks needed. Some CGM need calibration, as well as support services and digital data security provided by the company. Customer service programs to support resolution for issues like, for example, replacement of faulty sensors, including also the system troubleshooting if needed. Support and education for healthcare practitioners and patients, training programs, and digital data security, which should be considered as a priority. These are the examples of the CGM devices available in KSA. Some of them, they meet the standards. Some of them, they do not meet the standards. And we got together with some of the experts in the area, and we came up with some criteria that we are going to probably communicate to our Saudi FDA to unify really the standard for CGM, and just to when we want to make sure that whatever reaching our patient is not risk-free, but at least of known risk, which is acceptable, so they can benefit from CGM use. We have some recommendation, and mainly we have like to align with all the international standard criteria. And in summary, accurate real-time glucose measurement is essential for optimal diabetes care and timely informed decision-making. Beyond the price, accuracy, reliability, and safety of CGM devices are important. CGM marking is not always a quality standard. FDA is a quality standard, but standardization is still needed. ECGM, there is a short-term solution in Europe. ISO standard for CGM is the ultimate solution for all, but we might need to wait 2 to 3 years for this to happen. Minimum standard for CGM approval in the kingdom and probably in the Gulf state should be the standard, should be communicated to the regulating agency in the Gulf states. And I just want to tell you that accuracy and precision is not only important for patient, but sometimes it's a matter of life and death for some patients, particularly who are using insulin. With this, I end my presentation, and thank you very much for your attention.
Great. Thank you so much. Excellent presentation, very clear. Let's start with the questions now. If anyone wants to even chat, it's all right.
Dr. Bashar.
Yes, please.
I think this is the idea of really having those sessions to have interactive feedback from the audience. For the case I presented, I need to give them 1 minute just for the attendees, the participant. There are probably around 45. Who would think that the case of pemphigoid that I presented could have been caused by Ozempic? Yes or no? Just on the answer, on the questions and answer, please add your comment. Ozempic is the culprit in this case? Yes, no. And there was a question.
How soon after starting the Ozempic this started? Could you remind us?
That was few months, like maybe 2 months after starting Ozempic.
Okay. I think it's reported, but no, I'm not sure about this case.
Okay. Well, actually, it makes sense now because I looked it up. There was one attendee. He or she did not really want to put their name through, but I would like to thank them for their feedback. Actually, I looked it up, and there is a review article that published recently in Skin Appendage Disorder 2025 by Olivia Berg and its group. And they go over all the skin manifestation caused by GLP-1 receptor agonist. And it's interesting that we see quite frequently of those in our offices. And I'll list them quite briefly. One is urticaria at the site of the injection. And I had actually 2 patients with tirzepatide had this kind of reaction. Bullous pemphigoid, few cases have been described related to Ozempic, and now it's really confirmed Ozempic could cause a bullous pemphigoid. Ozempic face, where they lose the fat from the face. And I had one patient, actually, she had this kind of skin reaction. You look like there's no fat anymore, only skin and bone. This is facial hair loss is really common. That's an extreme, you get alopecia, that really could be some of the side effect as well of, those are the most commonly skin reaction. For those who would like, I could maybe post it in the question, Skin Appendage Disorder 2025. It's a review article, really exhaustive, very well written article. Thank you.
All right. Thank you very much. So it is possible then, and it is actually reported. I know that.
Yes.
Okay, so
There was a question for Dr. Ahmed.
Dr. Ahmed, I see that.
Actually, there is a comment.
Yeah, please.
Yeah.
No, I think it is a very nice question, actually, from Dr. Hanadi and Naqib, I think. Anyway, it's a very good question. She's asking about C-peptide was normal, and we excluded insulinoma on the case, which is the latest one that we saw. It's not insulinoma. She's asking why we did not do IGF, thinking about IGF-mediated hypoglycemia and checking IGF-1 and IGF-2. I think her point is well taken, but the only one thing that confirmed it's probably not the case, because in these cases, all of them are correct, but also the patient should have a suppressed, beta-hydroxybutyrate. And that patient, if you remember, has a high beta-hydroxybutyrate, causing it to be, like a fasting, somebody who will fast for a long time and develop ketosis. So in these people who have IGF-mediated, they will have to have also a lower beta-hydroxybutyrate. So that's against it. But I think it's a good thought here that thinking about it, just for the purpose of discussing this is something we can think about it, but can be done anytime later on. But during the fasting is not probably the best time to do it. Can do it later on. But as I said, the patient is doing very well, and there is no other episode happening. But we have to keep in mind we should probably further look into things if this is happening again, to look into other causes, but not insulinoma. Now, this mediated, IGF mediated, usually just for the people who are probably not familiar with it, we measure IGF-1 and IGF-2, and there is a ratio, basically, and a high ratio of IGF-2 over IGF-1. They stimulate the insulin-like receptor and causing hypoglycemia, and the same thing, they will probably drop again the beta-hydroxybutyrate. I hope that answered the question.
Dr. Ahmed, may I comment here?
Sure.
Actually, I was interested from the case that you mentioned there's a tumor there, thyroid tumor, and it light up on the PET scan.
Right.
And then I looked it up, and there is one rare case, actually, of thyroid tumor that secretes IGF-1. And
Good.
usually those tumors are really large tumor. And maybe it's not coincidental. Maybe it is that tumor maybe to be implicated in this type of hypoglycemia that this patient had.
Yeah, the only thing I did, it was biopsied, that one, and they did not see something different than I think
Yeah, but it's a benign lesion.
Yeah.
You have to do like immunostaining on those lesions to find out whether it's secreting IGF-1 or not.
But for
But-
that case, it was a reactive hypoglycemia. It happened 2 or 3 hours after the OGTT in the first, evaluation. Dr. Muhammad, I'll move to you with a few questions. Do you think that CGM is reliable in ICU patients? Pregnancy?
Yeah, so there are lots of work now done in inpatient the management of blood sugar. Still, it is not the standard. It's not approved, and we probably it's not particularly in ICU patient. You want to be careful because they have lots of edema and they are hypotensive, and so it might not be accurate. But there are standards now or studies to try to standardize the use of CGM in inpatient, including one study in our center that we are doing now in cardiac patient. So I think in the future we will see something like that, but currently it is not approved for use in inpatient. Pregnancy, there are some sensors which are approved in pregnancy, and particularly Dexcom, G7 and OnePlus are approved, and Freestyle Libre it's approved in Europe for use in pregnancy, but not by the United States FDA.
How about if patients have hypoglycemic unawareness? Would you stop CGM? What would you do?
When sorry, what's the?
If a patient has hypoglycemic unawareness, would you still rely on the readings of CGM?
Of course, this is probably one of the patients that you want to use CGM because they do not feel the hypoglycemia. So you should be really giving them CGM to protect them from hypoglycemia.
Okay, good. Thanks.
As long as they are really following the standards, if you are using really a reliable CGM, then I think that's the way to go.
Dr. Ali has a question.
Hassoun, did you measure the cortisol when you do the 72-hour? Maybe I missed it.
Yeah, it was measured. It was measured. It was normal.
Okay.
The protocol usually measures whenever the patient is hypoglycemic, you must check the cortisol.
Yeah.
Okay, Dr. Muhammad, also, how would the lag time and rapid changes in blood glucose, affect the CGM accuracy actually in real practice? Lag time, rapid glucose changes after short-acting
This is
insulin.
what has been addressed by the ICGM and ECGM standards. So there should be tested when the blood sugar is rapidly changing. And you know the dynamic glucose region testing that we mentioned. So now there should be a meal challenge and also insulin challenge to make blood sugar really moves up and down quickly, so we can really reliably follow the blood sugar readings on the CGM. It should be the one with good performance standards. It should be good, but always ask your patient when you feel something is not right, then they need to double check with a glucometer.
Good.
Dr. Mohammed, if I may ask you also a question about always practical question. Patients saying there's big difference, as you know, between this and the SMBG. And so what we should tell them, what is the acceptable, and again, we do it usually in fasting time so that there's no issues with that. What is the acceptable percentage differences between the two?
As we mentioned if I show you in that criteria, so the 15, 15 and 40, 40 criteria. So within low range, below 70, there should be no more than difference more than 15 milligram per deciliter. And there should be no more than 1% more than 2% more than 40 milligram per deciliter. And in the normal range and in the high range, 15%, not like 15 milligram per deciliter, 15% from the difference.
Just related to this, Mohammed, if I may ask you also, we are always facing, and I think we always probably agree or been convinced that on the lower level, in the hypoglycemia, let's say less than 70, It's probably not very accurate. Have we done something to improve that aspect of this CGMS?
It depends on which CGM. So the good quality CGM, they should be accurate in the low reading, as we
Okay.
mentioned. And it should be within 15 milligram. But make sure that the comparison is also good, because some of the glucometers, they are not really good. And they
Agree.
have no good standard. So you need to know also the comparison is good. Otherwise, some CGMs is better than the glucometer.
Right. Thank you.
Dr. Ali, let me ask you about clinical clues that this is atypical or not your typical case of hypothyroidism. What kind of clinical clues you would look for?
For the presenting case I did,
In this case or other cases, when would you suspect other entities, not only simple hypothyroidism?
this is a difficult question because I mean, it has could be different presentations. The one that really, when there is this, there's no correlation between the clinical picture and the ultrasound picture. You will see, like on ultrasound, significant changes of thyroiditis, and then the clinical picture is very mild, and vice versa. This is where I feel that that's for me would be atypical. But there's no really, maybe make it you be more specific and guide me through what kind of answer you would like to for me to give you.
I mean, clinical presentations or abnormal labs or something like that. That
I
do
mean,
not.
the one thing here, when you look at the ultrasound, you have significant thyroiditis, antibodies are negative. Or you have significant antibody that are positive, and you look at the ultrasound is really minimal changes. So those changes do not correlate sometimes between what's on ultrasound and what's really in biochemically is showing. There is one question that really was asked by Dr. Osama Barakat.
Yeah.
Is COVID and is associated with thyroid antibodies? And if I may take 1 minute, yes, it is associated with the presence of thyroid antibodies. The mechanism, it's really, we don't know exactly why it is the case. I mean, some theories, there is immune dysregulation. Is it due to cytokine surge and really affecting the thyroid? This is a possibility. Are we dealing with what we call like molecular mimicry, like some viral proteins look similar to some of the viral of the thyroid component of the thyroid gland, and then the viral component is gone, and then you're left with the thyroid antigen similar to the viral protein and ongoing thyroiditis. There could be also sometimes, it triggers an underlying immune process that really is present, or it could be by being bystander activation of cells along the thyroid cells. So it is associated. You can have antibodies against glycosomal antibodies, against thyroglobulin antibodies, and there have been cases against TSH receptor antibodies. And the picture could be different. You might have transient thyroiditis. You might have like overactive thyrotoxicosis that gets reactivated, could be a little bit longer than transient in nature. So this is the type of picture you might encounter. Hypothyroidism has also been described too.
Ali, may I ask you if that is also related to the vaccination? Sometimes people talking about after vaccination.
Yes, I think it goes along with the vaccination. We have seen not only against the thyroid cells alone, it has been also about the ovarian cells. So you might have sometimes some irregularities are seen post-COVID vaccination. Frequently, women were coming and explaining that they have that period have changed, and it's not the same pattern that they had before. So you have different organs could be affected at different times. Yes.
Dr. Muhammad, do you really rely on CGM systems in modifying insulin doses for your patients? Totally, I mean, or would you ask for finger sticks and so on?
It depends on the CGM, of course. If you're
Yeah.
using a reliable CGM which is approved for decision making, like Freestyle Libre 2 or 2 Plus or 3, Dexcom, Smart Guide need calibration at least 2 times. So if you are using those kind of sensors, yes, you can allow your patient to take decision based on what the reading they see, unless they are not feeling or feeling something wrong. For example, they are feeling symptoms of hypoglycemia and the CGM is giving them hyperglycemia, then they need to double check. But otherwise, they
Yep.
can safely follow
But
what.
Dr. Muhammad, this problem seems really less now with the new pumps coming, like the Omnipod, and then which they have a predictive type of trend about really hypo or hyperglycemia. And the correction is done automatically by the pump, not so much by the patient or the physician advice. No?
Yeah, so the automated insulin delivery, of course, if the patient
Yes.
is on automated insulin delivery, then their problem is solved. The pump will correct, and the algorithm will correct the blood sugar. But again, they need a reliable sensor to do that.
Right.
That's
But
why.
meanwhile, we see, I mean, many patients that they are using what we call reliable sensors, but I mean, when you recheck, I mean, the difference is 20 and 30 and 40. So, I mean, when you're talking about type
Right.
1 or pregnant, or this is a big, I mean, difference, and probably modifying the dose of insulin, not always good.
Yeah, so of course you need to double check the comparison if it is good or not, and if not, sometimes there are some batches of the CGM is not good,
Absolutely.
or some
So,
batches are not stored properly. So if they are really noticing that, they need to change the sensor, and most of the companies will replace that faulty sensor for free.
but twice weekly, is that enough, as you mentioned? Twice weekly is to, I mean, calibrate.
No, the
Yeah.
smart guide, they need 2 times calibration. Yeah. For the 2 weeks.
And for many patients, I mean, we see clinically that, I mean, in the first day or 2 days is not that accurate. I mean, I don't know, maybe the last 1 day or 2 days, I'm not specifying any, I mean, specific meter, but overall, you might see the differences in the first and last days. All right, what do we have questions here?
Can I ask Mohammed again? Mohammed is our friend here, so we're going to ask you the advantage you are with us today. Maybe you can send us with your expertise about the, glucometers comparison. I'm sure you have probably access to this comparison schedule, a table, I mean, between them and also the CGMS. I would appreciate that if you send it to us, and maybe we can forward it to the audience as well, if that's okay with you.
Sure, yeah, definitely, I can do that.
Thank
Dr.
you.
Ahmed, how could you make a diagnosis of autoimmune hypoglycemia?
Autoimmune hypoglycemia. You're talking
Right,
about the antibodies, this measurement of insulin.
right.
Yeah. So in that case, you have the high insulin levels, measurement, and significantly high. We're talking about not just little high. And then that time you can get the diagnosis. Everything will be almost similar, going down of all this because the insulin is doing that. But it's a, episodic. I think if I remember, a patient from Al Ain came one time from your side, guys, that had been complaining that nobody have reached to the diagnosis, and even us, we could not reach to the diagnosis. She's having symptoms, and I think was one time measured was high, but at the other times it's not high. It's very confusing. It's not easy to diagnose, actually, in my experience.
And the antibodies, it should be high, the insulin antibodies.
Exactly.
Antibody is very high, the insulin very high, the C-peptide is not very high, high but not very high. When you compare to the insulin level, the insulins are very high.
I think the antibodies is the main issue. Antibodies, yeah.
Antibodies, if you check, yes, you will find them high.
And sometimes most of those patients have other autoimmune disease like
Exactly.
lupus or something.
Well, in this case, my case, it was Plavix induced. So after a few days of starting Plavix, started developing this.
It's interesting case.
That's good. You can reverse it. Excellent, because sometimes very difficult to find.
Yeah. Dr. Bashir Saleh, are you asking here or only saying hi?
He was asking initially. I don't know what happened. Maybe he changed his mind.
Yeah, he removed it, yeah. Dr. Osama, how are you? I have no more questions here. Dr. Ali, Dr. Ahmed, help me here finding questions. Dr. Muhammad.
Well, to Dr. Ali, may I ask Ali, since we are all together here, Ali, just something not related exactly to our presentation, but regarding the thyroid. As you know, we always trust your opinion. You're an expert in the thyroid. Now, the case we talked about, highlighting the PET scan in the thyroid, and we always remember, even in our board exam time, that what is highlighting the thyroid, it means something significant. So the question is, does it make a difference if it's a benign or it's a malignant? Usually when we worry about that, usually they think it's malignant. That's why you go and investigate. I think we'd like to comment.
That's a good question. Very good question. You have to be very cautious when you get a positive PET scanning within the thyroid. Okay, that could be, if it's diffuse, it might be inflammatory. If localized, you have to be a little bit more cautious. And then that's why you have to go back to your ultrasound. And because the risk of malignancy in those lesions is relatively high, around 20%. So if your ultrasound features are suspicious, don't rely on only one biopsy of Bethesda 2. You have to repeat the biopsy another time because the risk of having underlying malignancy is high. So I wouldn't rely only on one attempt. I'll keep my eyes open and then recheck with the patient in a few months' time.
Mr. Chairman, can we ask something not related? Is that okay?
Sure, yeah, sure. Go ahead.
We have the experts here now. The expert, Mohammed, I'm going to move to Dr. Ali, if you don't mind. Dr. Ali, what's happening with the molecular studies now with Bethesda 3 and 4? Is it covered by insurance in your side, other sides? How we can get covered?
I mean, I should ask you the question because really it looks like in Dubai, it is covered. The guys from the American hospital have been requesting the test and it has been approved. On our side, we have resistance. It's automatically rejected in Abu Dhabi. Some occasionally we do write a letter, and private insurance seems to be better than Daman. Daman is automatic disapproval. Private insurance, sometimes they do agree to do it. Now, CCAD now through like the NRL lab, which is the National Reference Lab, we're going to come up with something maybe affordable to patient to test for molecular testing as far as pricing is concerned.
What are the prices now, Ali?
It can range from 7,000 to 11,000, depending.
Yeah, it's about 8,000 now, going down from 20 plus.
Yeah, 20 plus. So it's coming down. And I think when we get it down to around 5,000, it will be reasonable for the patient to ask them really to put in that extra money because sometimes it's very useful as far as information is concerned.
And do you prefer Thyrosec over Afirma?
My tendency has been to go for Thyrosec because it gives you a little bit more exhaustive type of presentation, give you the risk stratification. It's more inclusive as far as gene expression classifier. But Afirma also is really very good as a negative predictive value. So if you have a negative result with Afirma, it's a very high predictive value.
I just have a case. I have two cases I've been exposed, not done with us. One, I did it for a VIP, went to the US, paid the money, 11,000, whatever it is, and they did Afirma. Unfortunately, the results came 50-50.
Yes.
Sometimes it's like wasting money, but coming with that much.
Actually, even with Thyrosec, I mean, when the result is positive and they tell you around 50%, you have to be cautious because even if they give you a positive result, you might have sometimes 50% chance it might be negative. So depending on the gene that you get and what gene is involved, then you can get a little bit more directive to take that in question and look back at your ultrasound. The ultrasound risk stratification is the most important tool that we have so far.
Well, it looks like surgery is better than, I don't know.
We're doing all this to avoid surgery, Dr. Bashar.
I know, but if you're doing it and you're not sure, and then you're going back to repeat it.
No, listen.
Very costly and.
let me tell you what, if your ultrasound features are reassuring, even if the result is positive, I still really rely on my ultrasound. You know, the ultrasound risk stratification is really quite important.
Yeah,
Right.
that makes sense. Absolutely.
Mr. Chairman, just one suggestion. You know, we're enjoying the interaction between us, but we would wish that our audience, you know, the attendee would have done this with us. Unfortunately, because it's not face to face, I wish that in the future that
Hopefully
would be
next
face
time.
to face and much more interactive with the people sitting and watching us.
And you have all guys there, Maher and Bashar, and many of them, Ahmad, many of them would love to, I mean, you know, always.
And I think really for future meeting, I think making it physical, I think
Yeah.
it has a lot greater value than doing it online. The case discussion, you need to have interactive session, not really online.
Exactly. Okay.
Well, I think with that, we don't have so many questions. The audience probably Saturday afternoon. So I think I would like to thank you all for your excellent contributions, and to the audience, some of them. And please, just if you want to get your CME, just please complete the evaluation. I'd like to thank Dr. Ali, Dr. Ahmed, and Dr. Muhammad for their great presentations. And thank you for joining us, all the audience. Also, I'd like to thank the sponsor, Abbott, for their sponsorship and support, and also the organizer. We look forward to seeing you physically, inshallah, next time. And have a great day. Assalamu alaikum. Please complete the evaluation form to get your CME. Thank you, Dr. Muhammad, Dr. Ali, Dr. Ahmed. Thank you so much. Thank you.